All right. Are y'all able to see the PowerPoint now?
Yes.
Yes? Okay, good. So it is a little after 9 o'clock. We'll go ahead and get started. Good evening, everybody. I'm Dr. LePage, and tonight we're going to talk about endocrine medications and particularly insulins and some of our thyroid medications and some of the disease processes that they treat and we use them for. So let's start with our objectives. Upon completion of the presentation, the participant will be able to differentiate between the types of diabetes and the treatments for each because, we do treat type 1 and type 2 differently. Apply the pharmacological principles of insulin and those anti-diabetic oral agents to the care of the patients with diabetes. Apply the nursing process and administration of these pharmacological agents and evaluate the effectiveness of these pharmacological therapies and provide patient education with each of them. So let's start with the two different types of diabetes. There's type 1 and type 2. Type 1, we know, is where the body makes no insulin and and the pancreas does not make any insulin. Could be due to an autoimmune destruction of the pancreatic disorder. I'm sorry, the pancreatic B cells, and it accounts for about 5 to 10% diabetic patients and cases. Most of the time, this is diagnosed in childhood. They can be as young as 4 or 5 years old when they're diagnosed with type 1 diabetes. Unfortunately, the younger they are, the more complications they tend to have as they age. Type 2 diabetes, kind of gave you a table here of the differences so you can see them side by side. Type 2 diabetes is the pancreas produces some insulin, but it's not enough. And it's characterized by a deficient amount of insulin or insulin resistance. And it accounts for about 90 to 95% of our diabetic patients. Let me just answer this email real quick. They're trying to load them, but y'all can see them. So let me let them know that you can see them. Okay.
I'm so sorry. We have to let our IT member know because when we have a one lecture and after we have a second, it will takes time. It doesn't let us sign it for your
Okay. So
presentation.
is there still
They have
people
to give us
coming?
little gap. That's happened yesterday. Yes, that's why I'm saying. Yesterday I get later and I try to contact with them. Nobody can help me, and my son helped me just figure out. And now also I missed first two slides in your when you started. It's take time. We have to tell the previous professor or the later start 5-10 minutes gap. We can just coming out and start the new one.
Okay. So
Sorry.
I'll go back to the beginning. That's fine. Not a problem.
Yeah, I think I think you should meet maybe. Thank you so much. Thank you.
Okay. So the first slide was just basically the outcomes and what the participants will learn by listening. This one here is your table between the two different types of diabetes because we're going to be talking about insulin and anti-diabetic medications. So I was just kind of going over the differences. I've given you a table between type 1 and type 2, and we're looking at pathophysiology, what the treatment is, and then what body systems can be damaged as a result of the diabetes, because there's always those multi-system problems that occur as well. And then there's some non-pharmacological treatments as well. So pathophysiology of type 1 is where the body does not produce any insulin. It's an autoimmune destruction of the pancreatic B cells, and it accounts for about 5 to 10% of the diabetic patients. We know that type 1 diabetes is typically diagnosed in childhood or young adults. But what I was saying is that we're seeing children younger and younger being diagnosed with type 1 diabetes. And unfortunately, the younger they are to get diagnosed, the more complications they have as they age. Type 2 diabetes is a decreased amount of insulin that's produced by the pancreas, and it's characterized by insulin resistance and a deficiency. So the body does produce some insulin, but it's just not enough. And that accounts for about 90 to 95% of our diabetic patients. And type 2 diabetes is diagnosed during adulthood. So a lot of it can be attributed to diet, lifestyle, and then we all know that there's risk factors for getting diabetes. So the treatment is going to vary depending on the type. Type 1, these patients need insulin from the get-go. Right off, they need insulin because their body is not producing any of it. And remember that insulin is a hormone that normally circulates in the body. And then type 2 diabetes, they require oral anti-diabetic medications, sometimes a combination of that oral anti-diabetic and insulin. And then now they have a lot of these new GLP-1s that are out there that also control diabetes as well and blood glucose levels. We're not going to get into a lot of those because NCLEX is not testing on those yet, but maybe in the future they will because they haven't been out long enough for a lot of studies to be done on the long term. So what are the body systems that get damaged with diabetes that goes uncontrolled? And over time, you're going to see that it can damage the nerves, the eyes, the nerves causing diabetic neuropathy and peripheral neuropathy. The eyes, these patients can go blind, unfortunately, but they start with glaucoma and can progress to blindness. And then heart disease, there's that triad of hypertension, coronary artery disease, and diabetes. And then the kidneys, hypertension and renal failure. So your non-pharmacological treatment, these patients with type 1 require insulin, but they also require some lifestyle changes. Definitely need to be monitoring their blood glucose frequently during the day. So they're more than likely going to be getting 3 and 4 sticks a day for checking their blood glucose. Exercise can help. And then sometimes if it's really severe and they are obese, sometimes weight loss surgery helps. Your type 2 diabetics, lifestyle changes, blood glucose monitoring at least once a day, exercise, and then weight loss as well. Now, your non-pharmacological treatment is in addition to your oral anti-diabetics and your insulin. So when we're talking about non-pharmacological, I see somebody put a question in the chat that said, I thought non-pharmacological treatment for type 2 is to control their diet. Well, it is, but oftentimes these patients require pharmacological treatment as well. So they're not going to put them on oral anti-diabetics and not educate them on lifestyle changes, diet changes, and those kind of things, and then exercising. So when we look at the risk factors for type 2 diabetes, the factors that contribute to type 2 diabetes include obesity, impaired glucose tolerance, insulin resistant, ethnic background, specifically our African American and Asian populations tend to get diabetes type 2 more than some of our other populations. A sedentary lifestyle can lead to it, so encouraging exercise young is really good. Family history of diabetes, think about how those families eat and, some of our cultures. I grew up Italian and we had pasta every Sunday, which is a lot of carbs. And think about the age. As we age, the more prevalent it becomes to develop type 2 diabetes because of our history of not eating right and our lack of exercise. We see a lot more diabetes in our American culture, which is sad because think about the foods we eat as well. And then type 2 diabetes plays a role in polycystic ovarian syndrome. And these patients use metformin or glucophage, it's the same medication, to help ready the uterus in order to get pregnant. So therefore, we're using some of our oral anti-diabetic medications, specifically metformin, for other things other than just diabetes. So that's kind of important to know as well. So when we talk about our oral anti-diabetic agents, is type 1 is genetic. They can both be genetic. Diabetes in and of itself. When we talk about our oral anti-diabetic agents, sulfonylureas are your first line drugs. We use them for type 2 diabetes and that polycystic ovarian syndrome, specifically metformin. But there's two medications that are frequently used, metformin and glipizide. The onset, peak, and duration of the metformin particularly is up to 2 hours for the onset. The peak is usually 2 to 3 hours, and then the duration is about 4 to 9 hours, which is why we typically dose metformin twice a day. When we talk about glipizide, you'll see on the bottom, I put some asterisks and some stars down there, is because glipizide tends to have a longer half-life. That's usually 12 to 24 hours. So think about some of our older patients, and the presentation slides are too small, kindly enlarge. Well, there's been a problem with the slides. So let me see if I can enlarge them. We're kind of doing a workaround right this minute. I don't know that I can use the presentation view or the slideshow view because, oh, there we go. Okay. Yeah, but it's not. Okay, there we go. All right, is that better? Okay, good. So when we talk about these medications, the glipizide has a longer half-life, and I do have that information on there as well. I did take care of a patient one time. She was a little older lady. She was in her 80s, and she came in before my shift started at 7 a.m. in the emergency room, and she was hypoglycemic. She had already received D50 to get her blood sugar up, and they had already fed her. Well, when I went and did the recheck of her blood glucose, she was still low and she was starting to get a little lethargic, which we know are signs of hypoglycemia. And this went on. I think I fed this lady about 5 sandwiches, and we gave her almost 4 doses of D50 to get her blood glucose up. And then we finally realized that she took her glipizide later at night than what she typically does. She took it at almost midnight versus the 6 o'clock that she normally takes it, because she was out that night at a family gathering. So because of the half-life and the duration of that medication being 12 to 24 hours, she was becoming very hypoglycemic. Unfortunately for her, she wound up being admitted because we couldn't get her blood sugar to stay up. So, and think about, she had lost some weight, she said. She was an older lady, 80 something, I think she was 83 years old, if I recall correctly, but she was all of about 110 pounds. So dosage, and when we talk about the duration of these insulins and medications, it's really important to factor that in, especially their age and their weight as well. So our routes for our anti-diabetic medications is oral, because they are oral anti-diabetic agents. Some of the side effects are diarrhea and GI upset. So there's things we can do as the nurse to educate them to combat some of these, especially with the metformin. Diarrhea is a very frequent side effect, and it becomes aggravating to these patients. So they'll become non-adherent and they'll stop taking the medication because they don't like the diarrhea. So educating them, and there's things that they can do to combat that. We could tell them to eat a brat diet. We could tell them to make sure that they stay hydrated, and to combat that GI upset. Some of the other side effects is they get a loss of strength or energy. And then with any of your oral anti-diabetics, they can lead to lactic acidosis and, of course, low blood glucose. Metformin does not drop the blood glucose as frequently as the glipizide does. So kind of keep that in mind as well. What is going to be our patient education and our nursing interventions? We're going to want to monitor that blood glucose at least weekly. Educate the patient on the signs and symptoms of hyper and hypoglycemia so that they don't start to get really bad and develop those signs and symptoms. So weakness, tiredness is a sign of hypoglycemia, and then increased thirst and urination are the two main ones with hyperglycemia. Tell the patients to stay hydrated as long as they're not on any fluid restrictions. Educate them on the side effects and how to manage that diarrhea like we talked about. And then an important key factor here is metformin and CT contrast do not mix well together. And we have to educate these patients if they're getting a CT scan with contrast that we need to hold their metformin that day or the day before. Unless it's an emergency, they need to hold it for 24 hours before the CT exam, because the combination of the two can increase their incidence of lactic acidosis and then possibly cause renal damage. The dye in the CT contrast in and of itself can cause renal damage. So a lot of times these patients have electrolyte studies done prior to a CAT scan, especially if they're using contrast dye. Any questions so far with the oral anti-diabetic metformin specifically? Okay, we'll keep going. So the other one is your glipizide, your glucotrol. Again, it is an oral anti-diabetic, and it does help stimulate the release of insulin from the pancreatic beta cells. It is used for type 2 diabetes. The peak is 1 to 3 hours, and the duration is at 12 to 24 hours. So some of the side effects are going to be those signs and symptoms of hypoglycemia. Some of your GI upset, the diarrhea, the gas, and the bloating as well. There are no known interactions of food or drink. It does not interact with CT contrast as much as the metformin does. But if you have an older patient with some kidney dysfunction and they're going for a contrast, you probably want to check their renal function first. This medication does interact with a lot of the alternative therapies, and especially those alternative therapies that are known for lowering blood glucose levels. So we want to educate the patient on that interaction. It does also interact with fluconazole diflucan, which is one of your antifungals. And then with any of your oral anti-diabetic medications, you should be monitoring or talking to the patients about using over-the-counter medications, because a lot of those, especially your cough syrups and your liquids, contain a lot of sugar. The new thing one of the new things that's out there is all the gummies. You can take vitamin gummies for calcium. You can take vitamin gummies for vitamin C. For any of your supplements, you can get in a gummy form. But if you ever look at the labels of those, they are 2 and 3 grams of sugar per gummy. So like if you're taking a calcium gummy, you need 4 calcium gummies to get the calcium dose for the day. So if that's 2 and 3, that's 12 grams of sugar right there, which could be a lot and elevate somebody's blood glucose level. So educating these patients on those over-the-counter medications is really key too. Any questions? You guys are quiet tonight. All right. So let's talk about our signs and symptoms of hypoglycemia, right? So it's characterized, oh, geez, I put 770. I'm sorry about that. It's a blood glucose level less than 70. I guess my fingers got happy. It's blood glucose less than 70. Causes toxic dose of insulin, which means they get too much insulin or they haven't eaten enough to sustain what the dose of insulin that they got. Eating too little food. Illnesses, if they're vomiting a lot, that can decrease their blood glucose. And if they're having severe diarrhea and becoming dehydrated, that can also lead to hypoglycemia. Alcohol intake can also cause hypo and hyperglycemia, depending on what type of alcohol they're drinking. Strenuous exercise can also cause hypoglycemia. So a lot of times we need to educate these patients to monitor their glucose while they're exercising as well. And then childbirth can either cause hypo or hyperglycemia. So some of your signs and symptoms of low blood glucose is a headache. These patients start to get shaky. They tend to feel hungry. They tend to start to get diaphoretic, a lot of tiredness. It's anything that's going to lower their metabolism. They tend to get weak. They can get a little confused. I used to work with a girl in the lab that had gestational diabetes. And she was on insulin, and there would be days where she would start talking out of her head. And we were like, Gladys, what's going on? What's your blood sugar? And she would inevitably eat something, when we kind of assessed her and talked to her, she had eaten something the day before that she probably shouldn't have eaten. And at night, of course, her blood glucose was elevated. So she dosed herself appropriately for what her blood glucose was. But then her body, because of the pregnancy, she would become hypoglycemic. So really a lot of education with her and telling her, you got to stop eating the bad stuff because it's going to raise your blood glucose. And then you're going to take too much insulin because the next day it's going to affect you. So a lot of education with these patients. Most of our facilities have diabetic educators. So getting them in with the diabetic educators early to get teaching and education is really, really helpful for these patients. Hyperglycemia it's characterized in by definition is a blood glucose greater than 125. But it's a consistent blood glucose, and typically we don't start treating these patients aggressively until it becomes well over 200 and consistently. Some of the reasons for elevated blood glucose or the causes could be illness. Think about if your body is stressed. I tell students anytime a patient comes in the hospital, their blood glucose is probably going to be elevated. Eating too much carbs or sugar. Remember, carbohydrates turn to glucose in the body, and once they're metabolized. Stress can elevate somebody's blood glucose level, and then in administering an incorrect insulin dose or taking too much by accident. 1 unit of insulin can cause a patient to become hypoglycemic if they're, and by giving 1 unit either way could cause problems. Or if we give 1 less unit, these patients are not getting enough insulin and they can become hyperglycemic. So insulin, what does it do? It promotes cellular uptake of glucose to lower those glucose levels. We use it for hyperglycemia and DKA, which is diabetic ketoacidosis. Some side effects is hypoglycemia and hypokalemia. Insulin can decrease serum potassium levels. So one of our nursing interventions is going to be to monitor this patient's potassium level and make sure that they're not becoming hypokalemic. Because what could happen if somebody becomes hypokalemic? What body organ does it hypokalemia affect?
The heart.
The heart, absolutely. They can have some cardiac arrhythmias, absolutely. So it's real, these patients are sick, and good monitoring and understanding what these medications can do is really going to help you care for these patients. Unfortunately, insulin does interact with a lot of different medications. Your thiazides and your glucocorticosteroids can increase blood glucose levels. And we know steroid medications do increase blood glucose level. So a lot of times, and I see it real frequently, patients will come in, especially our non-insulin diabetics, our type 2 diabetics, will come in with a respiratory issue, and we'll give them Ciamedrol and our glucocorticosteroids. And then we also cover them with regular insulin. So in the hospitals with our students, when we walk in and the patient says, I don't take insulin, I'm on pills, we really need to educate them and understand that because they're on these glucocorticosteroids, they're now being covered with insulin for a short period because those steroids increase their blood glucose levels. Beta blockers and alcohol, your beta blockers also interact because think about what beta blockers do. If you were on last week when we talked about cardiac medication, our beta blockers lower our heart rate. So that could mask the signs because it's lowering. Remember, tachycardia is a sign of hyperglycemia, and that beta blockers are masking those that elevated heart rate. Alcohol is also mask the effects of hyperglycemia as well. Some of our nursing interventions, lipohypertrophy, does anybody know what that is?
Accumulation of the fat in the body.
Yes, good job. It is. It is. I'm sorry, what were you going to say?
Yeah, in the abdominal wall.
Yep. So they're tiny areas, and they typically occur where the patients are not rotating sites. So that's why we want to get them to rotate. They're very subcutaneous, and they will occur a lot if you're giving the injection in the same area. So that's real important to rotate sites. Insulin is one of those medications that we do have to double check with another RN. We definitely want to make sure, especially if we're giving them regular insulin, that we have a food or a snack within 30 minutes of administration, because once we administer it, remember the onset time. And I do have a slide coming up that will give you the peak onset and duration of the different types of insulin. But think that's why it's very important to understand those peak onset and duration, especially for insulin, because we want to make sure they don't become too hypoglycemic. If we're mixing insulins, here in the US, we don't do a lot of mixing insulins anymore. A lot of our nursing homes, we still do mix, but a lot of times they come already in auto injectors, or they come pre-mixed, or you get your Novolin 70/30, which is 70% MPH and 30% regular, and you just calculate the units according to the type of insulin that they're getting. But if you do have to mix the insulin, remember you're going to mix clear to cloudy. and your regular insulin is always clear, the cloudy insulin is going to be your NPH insulin. Regular and NPH. Yes, that is correct. You want to keep the vials refrigerated after they're opened. And you want to use your insulin specific syringes, which are measured in units. We do not round insulin. So when it depends on the facility that you're at, how they calculate it. Sometimes they'll give you a sliding scale and tell you if the blood glucose is between 200 and 220, you're going to give 4 units. 220 to 250, you're going to give 5 units. It just depends on the facility. Sometimes we have to do blood glucose minus 100 divided by 30. And you may come up with a dose of 4.2. You would give this patient 4 units. There's no way to calculate 4.2 units, and we don't round up on insulin or round down. We just give the 4 units. Obtain a blood glucose prior to administering insulin. Again, if it's too low, we're not going to give them insulin because we don't want to lower that. And then we do need to tell these patients if they're taking insulin, remember the body normally, because our blood glucose levels normally drop between 2 and 4 in the night while we're sleeping. So we want to educate these patients at least once a week or their family members to wake them up and take their blood glucose to make sure that they're not dropping. There are a lot of 24-hour monitoring devices that are out there. So that kind of helps. And we'll talk about those when we talk about insulin pumps in a few minutes. And we definitely want to monitor their hemoglobin A1C. Do y'all know what hemoglobin A1C measures?
Isn't it like 3 months worth of like how your blood sugar is like progressing or what's happening?
Yes, right. So it looks at the previous 6 months and it kind of averages it and it will give you a number. Here it should be less than 6. In the United States, we go by less than 6. So monitoring that and keeping it low. Patients who are on oral anti-diabetics will have monitor their hemoglobin A1C frequently to see if that medication is working. If a patient comes into the emergency room in DKA, which is your diabetic ketoacidosis, very high blood glucose, we really don't need that hemoglobin A1C right now, right? It's not going to do anything for us because they're in front of us with a very elevated blood glucose. We need to treat that blood glucose right now. So obtaining a hemoglobin A1C in somebody who has DKA, we already know they're in DKA. They are not having a good monitoring system, or they're not maintaining their blood glucose. Does that make sense?
Yes.
Yes. I have a question.
Sure.
So about the injection. Before any injection, we don't have to measure blood glucose and reset the how many milliliters we need. It's supposed to be constant with diabetes 2 patient.
I'm sorry, say that again.
So when we have to do injection,
okay.
So we have to, before the injection, do we have to need to measure blood glucose level or no?
Yes.
Every time.
Every time you should measure the blood glucose level. These patients need, yes, because think about what could happen to this patient if they have a low blood glucose.
That's why
and you give them insulin,
and we're giving extra.
I'm sorry.
That's why I want to say if they low, maybe they need very low dosage, and with high, we need extra dosage. That's my question.
Right. Yes. So yes, you have to monitor it, and most often they'll be on what we call a sliding scale. So typically, in this area, it's we cover, which means we administer regular insulin for a blood glucose that's greater than 180 milligrams per deciliter. So if they're 180 to 200, it's usually 1 unit. If it's 200 to 220, it's 2 units. And it goes up according to how high the blood glucose is. If these patients are on, and now that's for regular insulin, these patients are on NPH and more of your long-acting insulin, those are routine doses. So those, yes, you still, every morning we get a blood glucose on our patients, typically at 6:30 in the morning.
Thank you.
Please, can you explain the interaction part? What interaction part? Does it mean insulin interacts with thiazide to give us negative or positive effect? Yes, it'll interact with thiazide diuretics to increase the blood glucose level. So you have to carefully monitor patients. It doesn't mean we don't give them thiazide diuretics, just being aware that it will increase the blood glucose level. So careful monitoring needs to be done. Does that answer your question? Okay. So I put together a table here of your rapid acting, short acting, intermediate acting, and your long acting, and the different onset, peak, and duration time, and some examples of what medications fall under those. So your rapid acting, their onset is 15 to 30 minutes. That's typically your Lispro or your regular insulin. So because of that, we want to make sure that this patient has food to counteract that, or they have a tray or at least a snack within 30 minutes after administering these medications. The duration could be anywhere from 3 to 6 to 10 hours. So they kind of last. And that's why we think about when we cover these patients or do AccuChecks, they're typically AC and HF. So we're doing them 30 minutes before the patient eats or 30 minutes before they're scheduled to eat their breakfast, their lunch, and their dinner, and then at nighttime, because we need to give these patients a snack at night. We may be doing a combination. Like I said, this patient may be on a regular dose of NPH, a certain amount of units, depending on what they have been averaging for their blood glucose levels. And then we may have to cover them with even more insulin, and that would be that regular or that Lispro insulin. Your long acting is your glargine, typically comes 100 units per a vial, and its onset is 70 minutes. So that takes a long time to actually onset and work. And then you see it lasts for 18 to 24 hours. So Levemir is another one of those long-acting insulins. So if somebody is dropping their blood glucose or they're dropping it too soon, they may give them a long-acting. If they're getting it twice a day and their blood glucose keeps dropping, they may switch them to a long-acting medication to keep it at a more steady rate. Or glargine. What do you mean, or glargine? I'm sorry. Well, Levemir and glargine are examples of long-acting. Does that answer your question? Yes. Okay, good. So there's a pretty helpful table for you to kind of get an idea of the peak onset or the onset, peak, and duration. Steps to drawing up the insulin. Again, we're doing clear to cloudy. So if we, because it's a glass vial, we have to inject air into it. So if we're drawing up our clear to cloudy, we're going to inject the amount of air into our NPH vial first, and then we're going to inject the air into our regular vial, because then we turn it over and pull up our regular insulin, because we're doing clear first and then cloudy. So that's kind of a schematic and a visual. I kind of like visuals. I think they're helpful for students. And you can see where you can't give 1.2 or 4.2 of insulin. It's even numbers. And you can see that by your syringes. Our insulin syringes here are orange tipped. So you'll see an orange tip with a very subcutaneous, a very small needle. And there's a picture of it. You see it has the orange cap on it. So some insulin delivery devices. We have some insulin pens where the patients will dial in the amount of insulin they need. So if they do a blood glucose and they need 2 units, they dial in 2 units and administer the 2 units. When they do it at lunchtime, they may need 4 units. So they dial in 4 units and then they administer the 4 units. The jet injector is typically your pre-filled syringes that have a set amount each time. And then your insulin pump is a 24-hour, 7-day-a-week continuous infusion of a very small dose. And we'll talk about our insulin pumps in a few minutes. So there's different types depending on the manufacturers and what the patient requires. Any questions with this so far? We're all good?
No, Prof. Please, I would like to have the table of the last 2 slides, please. Thank you. Yes.
This one?
Yes, this one.
Okay. You all will, these will be posted and you can get a
Okay,
copy of.
thank you so much.
You're welcome. So caring for patients with insulin pumps. So it depends on your facility. Patients do wear insulin pumps. We use them a lot for our pediatric patients, especially if the parents and the child can be compliant with it, because they don't have to be stuck as many times. The device on the left of that abdomen is a 24-hour continuous glucose monitoring device that will monitor their blood glucose. Some of these insulin pumps get really, really fancy. I had a family friend that their 6-year-old wound up having to come into my ER. He woke up in the middle of the night vomiting and really sick. The family thought he had a GI bug. Well, it turned out he was in diabetic ketoacidosis. He was 6 years old and newly diagnosed with diabetes. It was hereditary. Dad had it and his older sister had it. So over time, he was able to be put on an insulin pump. And they get these fancy things. I'm not technologically savvy, but I was like, wow, this is really cool. The mom could monitor his blood glucose on her phone. And while the kid was at school, if his blood glucose started dropping, the mom would be notified so she could call the school and tell them, or text him and say, eat a snack or eat something, eat some protein, eat some sugar, or take a sugar tablet, depending on what the blood glucose was, or turn the pump off. So patients, in order to be eligible to get an insulin pump, the patients or the parents must demonstrate the ability to adhere to the multiple daily injection regimen before they put them on the pump. They need to have their blood glucose really managed before they go on the pump. Strict monitoring of that blood glucose. So until they get a glucose monitoring, they may have to have finger sticks very frequently. There is a training that goes along with it, and they have to take that required training in order to get the pump. They have to be able to operate the pump, and then of course the device on the phone. I said I'm not technologically savvy, but if I had a child or a family member or myself that needed it, you know, obviously I would have to learn it. Adhere to counting carbohydrate intakes, because remember we said carbohydrates turn into sugar or metabolize into sugar in the body and energy. Be able to change that infusion set and troubleshoot. So that could be difficult sometimes. In case scenario, when patient blood glucose is too low, can we turn off the pump? Absolutely. You can turn off the pump, or you can have the patient turn the pump off. When patients, it depends on your facility and where you work. The facility that I worked at, the patients, it was standard that the patient discontinued the pump when they came in, because we didn't want them to get too much insulin, because we're monitoring it. They're in the care of us. So it just depends on your facility. Some of your pediatric facilities don't require the patients to turn the pump off because they're so used to monitoring it and managing it. So again, that's just a policy and procedure depending on the facility that you work at. Nursing care of that insulin pump. So the pump is set at a basal rate, and that basal rate is a small dose that is continuous. It's usually going to be less, and it's figured out according to the amount of carbs that they take in, and according to their blood glucose, what the blood glucose has been running. So they'll get that basal rate. They will also factor in their carbohydrate ratios, which means how many carbohydrates are they eating in relation to the amount of insulin they're getting. And then insulin sensitivity is the factor, is how the patient's response to the insulin is. How have they typically responded to that insulin? And we look at their weight, the type of insulin, the type of diabetes, their kidney function, and then the medications that they're on that might interfere or not interfere with their blood glucose. And then every patient has a target blood glucose rate or number that they want to keep that blood glucose at. And of course, it's going to be different depending on the patient, because we look at their age, their weight, their carbohydrate intake, and all of those factors. What do we need to assess and document? If they come in with a pump, we definitely need to assess the presence and the location of the pump. We need to put the pump manufacturer and the model, because if we need to call the manufacturer or if we need to know what's going on, that information is important. Most of these patients will have a card that they're told to carry in their wallet that provides all that information. The type of insulin, where it is insertion site. Most of the time, the pump is in their abdomen. The insertion site is their abdomen, and the monitor, the 24-hour continuous monitor, is typically on the back of their arm or on their abdomen near the pump. We need to know what their normal settings are, and then we need to assess the site of insertion, and then assessment of the glucose monitoring device where it's inserted. We need to look at that site, make sure there's no redness, no swelling, all of those things that we look at or we assess when we're looking at a wound or an IV or anything that we're doing. Any questions on these? Any questions on insulin and insulin pumps and the types of insulin?
No. Can you please, excuse me, ma'am, please, can you please explain more about the insulin pump, how it works, how it's been programmed? Thank you.
Okay, so it's going to be programmed individually. So there's no one set program. It could be everybody's basal rate is different depending on the individual patient. And they look at their age, their weight, the type of insulin that they're prescribing, and then their carbohydrate ratio and what their blood glucose, what the doctor wants their target number to be.
Okay, thank you, ma'am.
Ma'am?
Yes, I can hear you.
No, I got two people talking. Was there another question?
No, no other question. Thank you.
Okay. So let's do some practice questions. And while we're doing these, we'll talk about some tips and tricks for answering them. So a client becomes restless 15 minutes after receiving a dose of Lispro insulin. What is the nurse's priority action? So again, this is a priority question. What's the first thing we're going to do? Because remember, with priority questions, we may do all four of them. But what is the first thing we're going to do?
Check the blood sugar.
I think the B.
glucose.
The B, check the blood sugar.
Yeah, check the blood sugar.
Yep. Why are we going to, that's correct. Why are we going to check the blood sugar?
To see
I
the
think
level
first
of
thing we need to do is to assess, and assessing the patient is by checking the blood sugar.
Hypoglycemic.
Mm-hmm.
Yep. Because those are signs of hypoglycemia, right? And we know the onset of Lispro is short. So we gave it to him 15 minutes ago, and now we're seeing signs of hypoglycemia. So we need to know exactly what that is, right? We need to know what that blood glucose is so we could do something else.
Professor, that's, sorry to interrupt you. That's where we have to do 15-15. First, we check the blood sugar. After that, if it's low, we give 15 ounces of orange juice. And after that, we wait the 15 minutes and we go ahead and check the blood glucose.
So that could be correct. But if you're if you give them that orange juice or whatever you're giving them and their blood sugar doesn't come up, you don't really want to wait 15 minutes. So
Okay.
you should see signs of them improving. If they're deteriorating, we're going to do something before those 15 minutes, right?
Okay.
Because we don't want it to get too low.
Okay, that's when we, and if it's too if they're deteriorating, we have to go to the chart to see how much insulin we have to give after, or what. And
Well,
that
we're
may-
not going to give them any insulin if they're showing signs of hypoglycemia.
Mhm.
We'll wind up giving them probably
The
some
snack.
D50 or some sugar, something that's a
mean, I will-
sugar compound.
Okay, and I will wait another 15 minutes and I go ahead and do the sugar again, the test for the glucose.
Right.
Okay,
As long as they're coming around with you giving them the orange juice and the other things, you can wait 15 minutes. But if they're deteriorating, you don't want to wait the whole 15 minutes.
and the
You
last
gotta-
thing I will call the doctor because he's going to ask me what I did.
Yeah, exactly. So I tell students when you're answering these questions, sometimes that is the first thing you need to do. The other day we were doing some questions related to fat embolism. Well, the first thing we need to do with a fat embolism is get the doctor there. So you really have to understand each question stands alone. We don't always call the physician last, but we don't always call the physician first either, right? There's things we can do as a nurse beforehand because he's going to want to know what's that blood glucose level. He's going to need to know in order to tell us what to do next, right?
Well, the embolism is different because when you measure the oxygen and you see that oxygen is not improving, you automatically have to call the doctor for that, no?
So there's some independent and dependent nursing interventions that have to be done. And it depends on the question.
Okay,
So, and what the problem is, whether you call the doctor first or not. In this case, we need to assess the blood glucose level.
mm-hmm,
And then we're not going to stop the next insulin dose right now because the next insulin dose isn't going to be due for another 4 to 6 hours. We're going to have to reassess. We can't, glucagon is going to help increase that glucose, that blood sugar level. So, but we can't give them the glucose until we know what the blood glucose is, right? We're not going
yes.
to increase it until we know what it is.
Mhm.
So it's,
I
go ahead.
sorry, I have another question, but without healthcare provider, if the blood glucose not going up, after the orange juice or anything, without healthcare provider, we are not allowed to administer glucagon. Is that correct?
That is correct. You cannot administer glucagon unless you
Without,
have an order.
okay. So any case, so it means if it's not going up or any next insulin, we have to wait healthcare provider orders. Yeah,
Yes.
got it. Thank you.
Professor,
So, so
sorry to
there
interrupt.
is, go ahead.
That glucagon is not the one that you give when the patient is unconscious, that cannot responds to something like that. That's the name of
So, so glucagon you give, not, they don't have to be unconscious. If they have a very low blood glucose level, we
Oh,
can give glucagon. But you need a physician's order for that.
okay.
So here in the United States, we have things that are called protocols, and that and depending on where you work, as an emergency room nurse, we had standing orders that we could give some medication. So somebody asked, I always have to call the doctor. Yes, that is the most. Yes, and somebody just put in there, most of the time at the hospital, the patients have a standing order for D50. So that is correct, or glucagon. If a patient is getting insulin, most of the time there's a PRN order for glucagon and D50. But that's kind of reading into the question. So looking at just this question and what's the priority, it's you want to check the blood glucose level. So when you're answering questions, I tell students, get the clutter out of your head, get rid of that space, and just look at this question. There are a lot of scenarios of what ifs, but take the what ifs out, right? I'm looking at this question and my what ifs are gone, right? So try to just keep it to just each question.
Quick question,
Sure.
Professor. It's about the fat embolism. Like, if you have in your options that this patient is having like shortness of breath, chest pain, and on the options you have call the doctor and also raise the head of the bed up. What do you do first? Is it you just have to go based on what is being asked? Because if they ask
Right.
what's the priority?
Right.
Priority, is it
So
just
you
is priority lifting the head up or calling the doctor?
The head up.
so
I will
there
leave
were
the head up first.
so you're not going to be wrong with lifting the head up. It depends on what the scenario is. There's no definitive, this is what I do all the time, right? That's where that critical thinking piece comes in. And that's where you have to look at the patient and the situation. I just brought up the fat embolism question because those of you that were on last week, or when we talked about fat embolism, the first thing to do was call the doctor, because in that case, that's what we need to do. And because somebody had just said, we call the physician last. Well, not necessarily, in this case, we're going to check that blood glucose. We're going to give them that orange juice and we're going to check it again. We may not give them glucagon right away. We're going to call the healthcare doctor because he's got to tell us what to do next, right? if we don't have any standing orders. Does that help clarify a little?
Yeah,
Mhm.
thank you.
What if the patient is not conscious to take the drink, and the in the MA, she doesn't have a PRN order for glucagon? In that case, what do? We keep waiting for the doctor, or what do we do?
Well, you got to save the patient. So you can call a rapid response team, and those are nurses and physicians that will come and help you. If you're on the floor, or you call a code, you get help to help this patient if you can't get the doctor right away. Because our main concern is the patient, right? If you don't have that PRN or that standing order, you call the rapid response or a code. Depends on what your facility has or what your protocol is for your facility to get help and get somebody there. Your rapid response team and RRT, yes. Your rapid response team is made up of nurses, probably they're considered mid-levels, nurse practitioners or physicians. It depends on your facility. Some of them have ICU nurses who are trained and part of their rapid response team. The facility that I worked at, the emergency room would respond to all the codes. So the doctor and the nurse, the charge nurse most often, or whatever nurse was free. So it just all depends on your facility, but you got to help the patient. So you would call that RRT. You can also
Professor,
get phone orders from the doctor. Yes.
what about, okay, we talking about that set up in the hospital. What about if we working in a nursing home and you are the RN in charge, and we don't have that rapid response in the nursing home like in the hospital? That's mean you have to use your critical thinking, no, as a nurse?
Right. So what do you do? I've never been a nursing home nurse. So yes, save the patient, use your critical thinking, but I know in our area, they would call 911.
Oh,
Do
okay,
what they could and then call 911.
okay, all right, I got you.
Yeah. Yep. It's the same protocol in 911. Yeah.
Okay, oh, they will tell me what I have to do in the nursing home. Okay,
Well, the nursing home will, most often your nursing homes, you're going to have a lot of standing orders, but you always call 911 and get the paramedics there to help you because their scope of practice is more emergent. So they can definitely administer glucagon. And a lot
okay,
of times, again, most nursing homes have standing orders for emergencies.
okay, all right, thank you.
So a nurse is educating a client taking metformin for type 2 diabetes. Which statements should the nurse include in the teaching? So this is one of those select all that apply questions. So there's going to be more than one answer choice. So let's look at, I tell students, look at the answer choices and see what you think and compare them to each other. And we're talking specifically about metformin.
E, E.
So I see a lot of different answer choices. So let's talk about each of them. So what do you remember about metformin? Should we take this medication with meals to decrease the stomach upset?
Yes.
Yes, that is correct. If you miss a dose, double the next dose to ensure a therapeutic level.
No, that's not
No.
safety, no.
No. What could happen if we double the dose?
You
We
take
can make
toxic.
them,
Like It
we
might
could
become
drop their blood glucose, right?
Mhm.
So B is not a correct answer choice. We only have A so far. What about C? The medication may cause weight gain.
No.
And lose
No,
weight also
no,
to
lose
the
weight.
you lose
metformin.
weight. It makes
Yes,
you lose weight.
metformin, you typically lose about 8 to 12 pounds.
Mhm.
And so say they start the patient on 500 milligrams twice a day, and then they go up to 1,000
Mhm.
twice a day, they may lose more weight
Yeah.
because they're changing the dose and giving them more. So educating them that they may lose weight usually is
Mhm.
used for weight loss. It's not, we don't use metformin for weight loss. Usually is used for weight loss in diabetic patients. We don't use it for weight loss. It's for diabetes. D, limit alcohol intake while taking this medication.
Yes.
Yes, that's
Yes.
correct.
That is correct. So, Ozempic is for weight loss. Well, those are some of our newer medications, and NCLEX is not testing on those yet. Yes, Ozempic is used, but Ozempic also
It's
is
for
used
diabetic
for
patients.
diabetics. Ozempic was created for diabetics, insulin and non-insulin dependent diabetics, to help prevent cardiovascular disease associated with diabetes. So in your patients who are non-diabetics, those medications were causing weight loss. So because the drug companies can get lots of money and get it prescribed, that's what they're using it for.
That is sad.
Yeah, it is sad. LOA weight loss has taken it over. Yes, weight loss has taken it over. Absolutely.
Mm-hmm. That's
It
what
is,
the
it
money
is
is
very
now
sad.
for the doctor.
It is very sad. That's one of my really big bad pet peeves is the cost of medication and, you know, our vulnerable populations. You should stop taking this medication if you experience any diarrhea. That's not correct
Not
because
It's
we
not
know
correct
that's
because
a
it's an
side effect.
expected finding. It goes with it.
Exactly. It's an expected finding. So what are we going to do to combat this? We can educate the patient. We can tell them to eat a brat diet, that bananas, rice, applesauce, or apples and tea. We can also tell them to increase the fiber in their diet and then make sure they're staying hydrated enough to make sure that there's no problems with the dehydration. So our correct answers are A and D. Everybody see that?
Yes.
Okay. A nurse is caring for her clients with type 2 diabetes mellitus. Which medication should the nurse prioritize monitoring for hypoglycemic reactions?
Glipizide.
Glycoside.
Yeah. Why glipizide?
Because
Because because why?
It causes hypoglycemia.
Well, because it is hypoglycemia, but what's what we talk about?
Because it has a high glycemic control.
Yes, and yes, Eunice, it's long acting. It lasts longer. The duration is longer. So those other medications, they work by enhancing excretion of the hormones once the patient has eaten. But glipizide specifically is going to lower the blood glucose levels.
Professor, that's the medication that is good not 24 hours. This one is the long acting, the glipizide. No?
Glipizide, the duration is up to 24 hours.
Okay, all right.
Yes.
That's mean if the patient goes to surgery, they don't stop. You cannot stop giving their insulin, but you're giving the rapid acting, no? When they go for surgery, or they have to stop it.
So we're talking about two different things. Glipizide is an oral anti-diabetic medication. And if they're going, I'm not sure what you mean by if they're going for
If
surgery.
they have a procedure done the next day, it's okay that I could give this one, or because we don't stop the insulin when a patient goes for surgery, unless it's metformin.
It depends on what type of surgery they're having and what the medication is.
Okay.
So metformin, you need to stop 24 hours before
Yeah.
they have a CT contrast with CT contrast, because the metformin and the CT contrast can increase renal dysfunction. But the glipizide lasts, the duration of the glipizide is for 24 hours.
Okay. That's mean I will administrate the glipizide.
Well, I'm not sure what you're asking in
If
relation
he's going for
to.
surgery, I still will give
Okay.
that insulin to that patient on the glipizide.
Well, you're saying glipizide and you're saying insulin.
Yeah,
So that's two different things.
Yeah, I will give this to the patient if he goes to surgery, the glipizide.
So if he's going, it depends on when he's going to surgery. If he's going to surgery tomorrow, yes, I can give it today because it's typically administered in the morning. Typically, when a patient goes to surgery, they're NPO after midnight. So, it depends on what their blood glucose is measuring, whether they're going to give it in the morning.
Okay.
Sometimes, glipizide is a tablet. So you were kind of confusing me because you were saying glipizide and insulin. That's two different things.
Yeah, I made a mistake.
Yeah. Okay. So it depends on the surgery and it depends on what type of surgery they're having.
Okay.
A nurse is teaching a client about the proper administration of regular insulin. Which statements by the client indicate an understanding? So I see a lot of C's. I see some C, D's, and E's, and I see C and E. Y'all didn't pick A and B. That is good. Those are incorrect. We do not administer any regular insulin if it's cloudy. That means there's particles in it. Remember, regular insulin is clear. You should not inject. I should inject regular insulin immediately after eating. No, we want to give it 30 minutes before eating and then give them food within 30 minutes because of the onset time. I will draw up regular insulin first if mixing it with NPH insulin in the same syringe. That is correct. I will store the insulin vial in the freezer until ready to use.
No, that's wrong.
That is incorrect.
That is wrong. Have to be at room temperature.
That is very incorrect. Yes. Once it's opened, you do need to store it in the refrigerator and you can let it sit for 5 or 10 minutes to get it to be room temperature. We never put any medication in the microwave to heat it up, and we do not store it in the freezer.
Yeah.
And then E is I will rotate injection sites to prevent the tissue damage. That is correct. So your correct answers are C and E. Yep.
I have a question,
Yes,
Professor.
it can stay for 28 days. Typically, they wind up using it before 28 days with the amount of insulin that they give. But yes, it's good for 28 days once it's opened. Yes, what's your question?
So if you open the insulin vial and you store it, you don't store it in the refrigerator, but you store it in a very cool place. is it gonna affect the medication effect?
So that's
Like-
one of those like chemical questions. I can't answer that. I know we store it in the refrigerator. I know that's what the package insert says, and that's what we've always been taught, and that's what we learned. So,
They
what
have
would be a what would be a reason why you wouldn't store it?
maybe in a area where you don't have like refrigerator and anything, but there's a very cool place, like maybe it's like you're in an area where the temperature is like cool. Do you have to put it,
So
can
that's kind of bringing that outside information in. You know, I can only teach what's the right thing to do.
yeah.
And that's what I go by. I'm somebody that follows rules and regulations and policies. So I can't really answer that. I don't know what would chemically happen to it. But it's not the correct thing to do. So
Yeah, okay.
it's one of those that's bringing in outside information.
Oh, okay, thank you.
Sorry, I can't answer that.
I'm so sorry
No,
about
it's
the C. I just want to clear up. I'm so sorry about the previous question about C. If I understand correctly, so in the same syringe, first withdrawing regular insulin and after they mixing in the same syringe with NPN.
Right.
Yeah?
Right.
It's the same syringe, only first we're going regular and after this mixing with the MPH.
Yes.
Thank
That's
What
why
I mean, what I understand is I just memorized something when we did it. I was like, before I had it, I was having it a hard time to memorize that. So what I did is I would draw RN first, which is the R. Then I would do, after I become RN, then I'll be a nurse practitioner, which is the N.
Oh,
And
well,
I mean,
that's
it's
good.
kind of stuck right now.
That's
That's-
perfect. Thank
first,
you.
then
that's a good way to
nurse
remember it.
practitioner.
Thank
Good.
you. That's a great way to remember.
That's a good way to remember it. Yep.
Thank you. That's
Yep.
great. Thank you.
So clients with type 2 diabetes mellitus are scheduled for a CT scan with contrast dye. Which medication should the nurse instruct the clients to withhold prior to the procedure?
Metformin.
Yes.
Metformin.
Yep. So y'all got that. One of my concerns is I kind of saw everybody putting the answer in before I even finished reading it. Unless you're a speed reader, that was great. But really make sure you're reading all the answer choices. A lot of times, I see somebody going, he, yes. Because there may be a better answer choice. Just make sure you're reading all the answer choices and you're totally understanding it, because I remediate with my students that I teach in person full time. And 9 times out of 10, they're like, oh my God, Dr. LePage, I didn't read the last 2. I'm like, I know you didn't, because you know this. So make sure you're reading the question, okay? These questions, I don't want to say
That's
they're
correct.
tricky, but you can change one word and it can make it a whole different question. So really read the answer choices. So let's talk about the thyroid. What is it? It is an endocrine gland, and whoops, sorry about that. And its main role is to control metabolism. Where is it located and what does it look like? It's that small butterfly shaped gland, and we find it in the front of the neck. Hello, is this Zoom meeting recording? I joined a little. Yes, it will be recorded and posted later. And it's found in front of the neck. We need iodine, or the thyroid needs iodine to make these hormones and secrete these hormones that they do. So where do we find iodine? Where do we get iodine?
Salt.
Where?
From salt.
From salt, iodized salt. We get it in a lot of our foods. Yep, salt, foods. Good job. So the thyroid makes and secretes thyroxine, which is T4. It is that primary hormone that converts T3 through that deionization. And then the reverse I can never say this one, triiodothyronin is your RT3, and then it reverses the effect of T3. And then your calcitonin that also gets secreted is going to help with the calcium in the blood and how it circulates. So just like a little back pathophysiology of the thyroid. How does it function? It helps regulate the amount of blood that is pumped through the heart, and we assess that through the heart rate. So we can see an elevated heart rate. We can see a malfunctioning of it functions to help with metabolism, but if it's non-functioning, we're going to have a decreased or an increased metabolism depending on if it's overacting or underacting. Some of our mental health, brain development and mental health activity, it can cause mood and it can
je vais prendre son adresse au-dessus de ça. L'envoyer.
I'm sorry, are you asking a question? So it can help with our mood, our depression and anxiety, especially if it's hyperactive. It can make us very anxious. It helps control heart rate. So some of our supraventricular dysrhythmias or irregular heartbeats, we look at our thyroid function because a hyperthyroid can cause an elevated heart rate. It helps to skin and bone maintenance and our growth and development. And then it also helps with fertility. And again, if it's not functioning correctly, it's going to do the opposite, infertility, and can also cause irregular menstrual periods and cycles. So some of the factors that affect the thyroid: stress, infection, trauma, a lot of those same things. Factors that contribute to the thyroid hormones. Look at all of our supplements, our iron, our iodine, zinc, selenium. We know selenium works on the brain as well. And then your vitamins, vitamin E, some vitamin D's, vitamin C, and vitamin D. Again, vitamin D along with that calcium, right? Because that calcitonin hormone. So hypothyroidism happens when the thyroid gland doesn't make enough of the thyroid hormones. This condition also is called underactive thyroid, and these patients require thyroid replacement from medications. And the most commonly used one is levothyroxine. Over time, if these patients continue with hypothyroidism and don't get treated, they can have other health problems related to cholesterol and severe heart problems as well. So let's talk about levothyroxine a little. It is a synthetic form of hormones that increase the metabolic rate, protein synthesis, the cardiac output. So if it's increasing cardiac output, it's going to increase the heart rate, right? If it can cause, it helps with renal perfusion. Yes, patients are on these medicines lifelong. Oxygen use, thyroid also, and the levothyroxine will help regulate the body temperature to keep these patients from becoming overheated and sweating. And then blood volume and growth processes. We use it for hypothyroidism. We also use it for myxedema coma. It is given the IV route for that, and we'll talk about a myxedema coma in a few minutes. And then we use it to maintain thyroid levels after patients have had thyroid surgery, a thyroidectomy or a partial thyroidectomy, or radiation to the thyroid. It is contraindicated in pregnancy, but again, if the benefits outweigh the risks, then these patients may be on it. it's just used in caution. And again, I kind of mentioned in one of the seminars, and I tell my students all the time, every medication is contraindicated with pregnancy, right? So we really need to look at, you know, and the obstetrician is who's going to make the decision whether to give the patient the medication or not. Thyroid toxicosis is a condition that's characterized by too much of that thyroid hormone in the body, and it can cause and lead to adrenal insufficiency. And then we use levothyroxine cautiously in patients with diabetes because of that altered metabolism. If they have diabetes, they already have altered metabolism, right? And levothyroxine can cause an increase in that altered metabolism. Some of the side effects are excessive sweating. These patients tend to complain of insomnia, increased heart rate, headaches, irritability, all of those things. Remember all the things that the thyroid does and how it functions. This medication is a synthetic form of those thyroid hormones. These patients may have increased appetite, heat intolerance, and they tend to get some hair changes. Their hair will get really brittle and thin. They don't lose their hair, but they tend to get brittle and thin hair. They can develop some diarrhea and then altered blood glucose levels. So somebody put in the chat, so everything increases. Pretty much because we're giving it for hypothyroidism. So we want that thyroid function to increase, and it is a synthetic form of that normally circulating thyroid hormone. So what are some of our nursing interventions? It is PO, except with that myxoedema. We want to obtain baseline vital signs, their baseline weight and height, assess their cardiac status. We may need to get an EKG. We're going to monitor their thyroid levels because sometimes we need to adjust these medications. They are best to be taken on an empty stomach. And we want to tell these patients, do not discontinue the meds. Most often, these medications require lifelong therapy because of the fact that the thyroid is not producing enough of the hormones, and they need that boost and that synthetic hormone. The IV dose is used with mixed edema coma. And that is the rare and a very extreme complication of hypothyroidism. And it results in several different organ abnormalities and a very increased thyroid levels that can lead to coma, like it says, and an altered mental status. A mixed edema coma can be fatal, so we definitely want to get this medication in the patient, and it is the IV form. Somebody put in the chat, taken in the morning. Yes. What if the patient will need to go in for a procedure and this med usually taken in the morning? Do they put them on MPO? It depends. And again, it depends on the procedure, the surgery, and what else is going on with the patient. Sometimes patients get medications the day of surgery with a sip of water. Again, it depends on the surgery and what medication they're on. So corticosteroids, we've talked about these when we talked about respiratory medicines. If anybody was on, I think we did respiratory medicines last week. I would still give it to my patient. Well, not necessarily still give it to your patient. You have to follow the doctor's orders and the anesthesiologist, depending on, again, it's going to depend on what the procedure is and what medication we're talking about. So, not unfortunately, but administering medications prior to surgery is not considered an independent nursing action. That's something that does require the physician's orders. So we're not going to just go ahead and give it. So our corticosteroids are released by the adrenal cortex to decrease inflammation. We use it to decrease inflammation in the body for rashes, allergic reactions, anaphylaxis, a lot of respiratory issues. We can use it for lupus and a lot of our autoimmune disorders. We give it to our arthritis patients for short term sometimes. And for a lot of our patients who have eczema, we use the topical form of your corticosteroids. So you see the examples there. Prednisone is your PO form. Your cortisone or your hydrocortisone is your topical, or it comes in creams or gels sometimes. Your hydrocortisone can be IV or PO, and your methylprednisolone is your Solumedrol, and that's IV. We use Solumedrol in an acute asthma attack, respiratory distress. We talked about some of the medications. Your hydrocortisone, we talked about Decadron when we talked about epiglottitis and croup. And then with your anaphylaxis, which is your most severe allergic reaction, we use the Solumedrol in conjunction with several different other medications. Some of the side effects is GI upset. So if they're having a GI upset and they're taking the pill form, prednisone, you want to make sure that they're taking it with food. These patients tend to get an increased appetite and weight gain. They also get sodium retention. Can lead to long-term, if they're taking it over a long period of time, they can get some mood swings and then your steroid psychosis. Anxiety can make them feel shaky, and then increased blood glucose levels and high blood pressure. So if you think about sodium and water retention, that's going to cause your hypertension, your increased blood glucose, because it's a corticosteroid. So some of our nursing interventions, if we're giving it IV, it's going to be a slow IV push. We're going to monitor those blood glucose. We're definitely going to do a good skin assessment and then administer it with food if we're giving the PO form of it. So any questions? Let's go back and see if there's any questions so far with any of these medications. Will this be administered in the morning with food? Are you talking about the corticosteroids or the corticosteroids? So it depends on the form. Yes, I tell patients to take it in the morning because it can cause insomnia and anxiety and keep patients awake at night. There are the dose. Whoever has their mic on, can you mute? We're hearing a lot of background noise. If you could mute your mic, that would be great. If they're on a Medrol dose pack, that is gonna be, they start off with 6 tablets, 2 in the morning, 2 at lunchtime, and 2 in the afternoon or evening time. And then they're gonna decrease it by days, and they typically take it for 5 or 6 days. But those are, that's just if they're a lot of times post anaphylactic reaction or post allergic reaction, they'll put them on a Medrol. It's called a Medrol dose pack, and they'll take it 2 in the morning, 2 in the afternoon, or with lunch, and 2 in the evening time after dinner. And then they'll decrease it, and it's usually a 5 to 6 day span that they'll take these medications. So let's practice. A nurse is providing education to a client who is prescribed levothyroxine. Which instructions should the nurse include? So again, it's a select all that apply. So you're going to have more than one correct answer choice.
I think it's A and D.
I see all over A, D, E, A, C, E, and then a lot of A's and D's. So let's look through this. Let's go through each one and see what we think and why they're correct or incorrect. So take the medication on an empty stomach. That is correct because it should be taken on an empty stomach because it's going to increase the absorption. Take the medication at bedtime. Well, if we're taking it on an empty stomach, we don't want to take it at bedtime because we have a full stomach most of the time, right? And it could interfere with the body's natural circadian rhythm and therefore decrease the absorption of it. So we don't want to take it at bedtime. Take the medication with lunch. So that's kind of contradicting all the other ones. If we're going to take it on an empty stomach, we're not going to take it at lunchtime. Take the medication with a full glass of water. Yes, we are going to take it with a full glass of water. Number one, it helps the pill dissolve correctly. And then water aids in the absorption of this medication as well. And then take calcium supplements while taking the medication. Well, think about what the thyroid does and calcium metabolism or calcium production is in there. But it can interfere with the absorption, that calcium, if they get too much. It can interfere with the absorption of the levothyroxine and it's not going to work. So your correct answers are A and D. Everybody good with that?
Yes.
All right.
I have a question, ma'am.
Sure.
So for the levothyroxine, is it only taken when the patient is on hypothyroidism, or it can be used for hyper too?
So it depends on what their levels are and how hypothyroid they are. Levothyroxine itself is a synthetic hormone, so it's going to help build up the thyroid levels. So sometimes if these patients are on, have just a little bit of hypothyroidism, they may take it. Yes, it's only for hypothyroidism. E is not correct.
Okay.
I'm sorry. I have a question.
Sure.
So if we have a total thyroidectomy,
okay,
they prescribing levothyroxine also, yeah?
They might.
Yeah, but that time I read, they say they prescribing calcium supplement with them.
You were breaking up there. They say they what?
They prescribing calcium supplement also, supplement with the levothyroxine when we have a total thyroidectomy.
Okay, but that's with a total thyroidectomy. All this question is talking about, and it depends because remember, calcium.
Okay, this is only just a hypothyroidism. Okay.
Right, right. We're only talking about the medication and what instructions we're going to give about that medication.
Okay, specific disease. Okay, got it. Thank you.
Right. So again, leave that other stuff out, right?
Got it. Thank you. Got it.
Clear the head, right?
I know. Don't go details. Thank you.
Yeah, don't go there. Don't go nowhere but where you want to be, right here, right?
So the right answers will be A, D, and E, right? Or
No,
A and
the
D?
right answer is A and D. You don't give a calcium supplement.
Thank you.
Thank
Being
you.
a synthetic. So there's in here, being a synthetic hormone, it is a form of thyroid replacement therapy, yes. Therefore, it is given when there is a low thyroid levels in the body, yes. Hypothyroidism, exactly. So when do we take calcium supplements? So
hypocalcemia.
well, yes, for hypocalcemia, but like she was asking, sometimes we give calcium
After
supplements
thyroidectomy?
for thyroidectomy. Yes.
Yeah.
So don't, there's all different kinds of scenarios. Kind of stick to just what the questions are asking, because you can get way out there. The correct answers were A and D for the previous question. Exactly. A nurse is providing instructions to a client with hypothyroidism about taking levothyroxine. When should the client take the medication?
The answer is B.
The answer is B.
That should be before breakfast.
Before
Yeah.
eating.
Yep. Be focused. LOL. Exactly. Be focused. Yep. Stay focused on just the question. So somebody put in here hypoparathyroidism. I'm not sure what you're pertaining to or what you're meaning. And the correct answer is B, for be focused, like he said, for calcium that we are discussing.
Yeah, they discussed think about the parathyroid gland.
Okay.
That's more deeper. Don't go there.
Yeah, that's bringing the junk in. Keep the junk out, right? A client is prescribed levothyroxine for hypothyroidism. Which of the following statements by the client indicates a need for further teaching?
It should be A.
The answer is, hold on.
No.
The answer is A.
We're looking for the one.
No.
Yeah. Yes, you are correct. You're looking for an incorrect answer.
And it's the A, Professor.
Yes, it is
A,
A.
Professor, because it said with breakfast in the morning. It should be taken on an empty stomach.
Right. Exactly. A is the incorrect answer, which makes it the correct answer for this question, because this question is asking the patient needs further teaching. So this patient has responded by saying something incorrect, which means we need to give more teaching to help them understand. Somebody put in their critical thinking. Yes, it is critical thinking. A nurse is assessing a client who is taking levothyroxine for hypothyroidism. Which findings would indicate drug overdose?
Mhm.
I think it's B, heat intolerance.
B, because you got the
B,
symptoms are like
yeah, going into,
hypothyroidism.
heat intolerance.
Yeah. So why is it why is it not bradycardia?
Because bradycardia is a sign and symptom of
Of Cushing's syndrome, yeah, of hypothyroidism.
hypothyroidism.
Right. So if they had taken too much of it, they would be tachycardic, right? They would not be bradycardic. The heat intolerance is the correct answer. Constipation is a symptom of low thyroid hormone levels, and as well as fatigue is associated with low thyroid levels. And a drug overdose means the patient took too many, took two doses, too much of that medication, whether it be intentionally or accidentally. A nurse is monitoring a client for hypothyroidism who is on levothyroxine. Which of the following necessitates immediate reporting to the healthcare provider?
B.
Yep, you guys are good. It's all B. Everybody, it's B. Yay. Good job. So temperature at 99.6, that's not a, I'm not impressed, right? A sudden increase in heart rate can be symptoms of hyperthyroidism. Weight loss of 4 pounds in a month, that's nothing. I'd like to lose 4 pounds in a day sometimes, right? Somebody put A, B, A, D, and E, but this is not a multiple choice. I mean, I'm sorry, this is not a multiple select question. There's only one correct answer. And D is not correct because occasional headaches every week, you know, that's not anything to be really, really concerned about. So does anybody have any questions?
I just want to say anything coming acute, right away got to notify. Like the pulse, it just come, it just increase. So that's
Right.
spontaneous.
Yeah, that was the sudden. Yeah,
Right.
Sudden.
acute should be
So,
immediate.
and that is immediate, and that is the worst of the symptoms that are there, right? So that's what we kind of explained. So you have to evaluate all 4 of them and see which one is the worst. So again, a temp of 99.6, that's not so bad. That's not even really a temperature, right? An increase of heart rate, that increased by 20%. So that's a big jump. Weight loss of 4 pounds in a month, that's nothing, right? That's about a pound a week. So that's not too bad. Occasional headaches every week, it's occasional. That word occasional is kind of a key word in there. So I want to leave you with wisdom is not a product of schooling, but of the lifelong attempt to acquire it. And that's by Albert Einstein. I like to leave y'all with some positive things, especially late at night. Does anybody have any questions or clarification needed on anything?
When is another class? When do we have another class? Today's my first day.
Well, you can check the schedule. Are you asking when am I doing another class or when are
Yeah. I mean tomorrow.
No, not tomorrow. Sorry. I gotta sleep sometime. Next week I'm doing Tuesday and Wednesday night, I believe. Let me look real quick.
That's good. Wow.
Yes,
I
next
just
week.
want to thank you, Prof. Thank you so much.
You're welcome. Yes, next week I'm doing Tuesday and Wednesday. Most weeks, I do Tuesday and Thursdays. The first night I do the childhood illnesses, and then the second night I do pharmacology.
Okay. I used to mix. I sometimes I mix up hypothyroidism. I know it has something to do with Cushing and Addison
So
disease.
hypo is going to slow down, and hyper is going to
spike up.
increase.
Okay.
Yes. I'm looking for my paper with the topics. I'm sorry. Give me a second. So Tuesday night, I am doing endocrine type 1 diabetes and ketoacidosis. And then Wednesday night, I'm doing psychiatric medications. So Ferdinand put the link to the Telegram link in there that people had wanted. My time is, yes, thank you. He put the schedule in there. For the whole month of April, I'm 9 to 11.
So, Professor, so Tuesday you're going to be teaching what? I'm sorry.
It's endocrine, DKA, and diabetes.
Okay. Thank you.
And
ma'am.
then Wednesday is psychiatric meds.
Oh, that's good. Thank you so much.
Is it possible to have psych meds lecture on Tuesday?
Okay.
Sorry, no. It's already set.
Well,
Yeah,
we need to
it's
able
9,
central
it's
time.
not Central Time, it's 9 to 11 Eastern Time.
Oh, Eastern, okay.
Is tomorrow Endocrine Farm? No, today was Endocrine Farm. It says in the schedule tomorrow Endocrine Farm. No, it's today. Ferdinand, can you check that? Somebody's saying it says the 4th.
May I ask you a question?
Sure.
So I took NCLEX like months and a half ago, and unfortunately I failed.
Okay.
But I wasn't like really preparing because I wanted to know what it's about. I just wanted to go and to see maybe I'm gonna have a good luck and I will pass. And then I will receive the CPR report. You know how they're sending the
Right, right.
and it's so hard to understand. It's like it's basically I have to go all over again and study again because most of the subjects it's saying I'm above or near passing.
Okay.
So how I can focus or how I can more,
Okay.
I don't know.
So give me 2 seconds and I'll answer that. Ferdinand, somebody is saying that the schedule says that I'm doing endocrine on the 4th, but endocrine was tonight. So a couple tips. What else in the report did it say? No, I cannot do endocrine again tomorrow. Sorry. What in the report does it tell you to focus on, or does it not tell you that?
It's not telling me focus. It's just giving me like, it's not in front of me right now. It's just giving me
Okay.
average report, and it's just saying where I'm above the average passing, where I'm near passing, and there was only like 2 below passing grade.
Right, but is there does it tell you the content?
Yeah,
That
it's
you're
telling me. Yeah.
okay. So NCLEX is an exam that's adaptive. So there's a threshold. You have to meet that threshold. And if you're below it on a certain content, they'll continue to give you that content so that you can get above it. But if after, it may be 10 questions, it may be 20 questions. If you're not getting above the line, then they'll move on to another topic. So it should break it down as to what topics and what area you need to look at.
So I should focus on the below.
Okay, so somebody put in here, it does not break it down. It just states, for example, analyze cues above, near, or below. Okay, so analyzing cues is one of those higher level critical thinking items. And that is one of the things where it will not be a specific question like, what is the normal CBC? It will give you a value for a CBC, and you will have to look at it and you will have to critically think what could be going on with this patient. So say it gives you a hemoglobin of 7 and a hematocrit of 30. That's low, right? And your patient could be fatigued and weak, which means they could be anemic or they could have some bleeding. So you have to analyze, what does that information mean? And then how do you apply that? What do I have to do for this patient? So if the patient's anemic, There's several different things we can do. They may need blood. They may need some rest. They may need some oxygen. It depends on what's going on with the patient. Did you graduate here in the United States, or are you from another
Yes, in
country?
Florida.
Oh, in
Miami.
Florida. Okay. Okay.
I want to say something.
Okay.
It's NCLEX is very complex. Sometimes when they give you the result, you see you below on some point. You got to focus on it, but you still have to work on the one you're above, because this time you can be below and you don't focus on this, but you say, hey, I was above, and you don't focus on them. And
No.
when you come back now, you below on them. That's best for you to restart all over, but you focus more on the one you below, but you still go back, focus on the one you was above too, because it's gonna change. You're
Yeah,
not gonna get the same answer
Right.
on NCLEX.
Right. And that's what makes it adaptive. So if you look at it and it says analyzing cues, that is one of your higher level cognitive learning styles. So practicing questions. I tell students all the time, you should be really practicing at least 50 questions a day. And it doesn't really matter the content, it's just practicing the questions and how to take the test. Where in Florida did you graduate?
I went to Southeastern College in Miami.
Okay. I'm from South Florida. That's why I'm asking.
Oh, okay.
Yeah, I'm from South Florida. So I would go back and look at your content. And at your college, did you take like a readiness exam?
We took ATI.
Okay. So
Yeah.
ATI gives you a really good breakdown. I use ATI here in Georgia. It should tell you ATI would give you your predictor, and it would also give you those areas where you're weak in, because it does break that down for you.
I'll be honest, I didn't like the ATI because it's nothing look like the NCLEX. So it
Oh,
kind of confused me. So I found the
okay.
best, the NAXLEX website.
Yeah,
And
Naxlex is good. So
the
then,
UWorld,
right.
Sanderson, those
Okay.
three website, and the Mark
So,
Klimerk. That's
so here at Naxlex, you have questions that you could be practicing.
yeah. I'm doing like about between 200 to 110 a day.
Oh, wow.
Just from
Okay.
this website.
Okay, great. That's what you need to be doing, is
There are
practicing
some
questions.
websites that are confusing me because some website giving me one lab value and then the other one give me different one.
So NCLEX will give you the lab values, the normals, and those are going to be a range. They're not going to be completely off. It depends on what lab a lot of facilities use. So NCLEX will give you lab values that are normal.
So, does this website, the Naloxone, does it have a Cubase like UWorld and the other one? Does it have a Cubase?
Where at Naxlex? Yes. There's lots of practice questions. I actually do. I
You
have
have
Where's
seen
the
it?
some
CAT.
variance between the listed
There's on the
schedule and
left
the
side, you
one.
have the CAT questions. It's like 85 each one.
Right,
And you
right.
have the RUT, it's 110, and it's not giving you the answers right away. Just when you finish with the 110,
Right, when you
then
finish
it's
with the
tell you.
110.
And it's give you rationals. So learn also from the rational. It's also
Oh,
good.
I thought
Exactly.
you see how the other ones give like Cubase, like I don't know how, like you do the question. I don't know how, if you understand, if you have like UWorld, you see how it works, like the Cubase.
Yeah, here it's same thing. It's kind of same, similar.
Yes, yes. So you have to go on the Naxlex site and you can generate your own types of questions.
Okay.
You can do some of this standalone and the readiness. I've done recordings for the categories. I've done category 3. I don't know if those are all done being edited yet or if they're up. And I've also done recordings for the readiness assessment test exam 1. So, and there's other tutors that have done, we've answered the questions and then we talk through what the rationale is, why there's correct answers, why there's incorrect answers.
That's
And
me. Sorry, Professor.
Ferdinand put it in the chat, the site to go on and get your questions, to do the practice questions.
That's mean you guys have contents because this class is about contents too.
Right. This is, yes, the tutoring is about content. So I would listen to as many as the classes you can, because the content on NASLEX covers everything that's on NCLEX, all of the tutoring sessions.
Is it true that in Florida there's a law that you allowed to take 3 attempts and then you have to do like a recovery class? That's what I heard.
I don't know. I haven't lived in Florida since 2002. And like I said, I took my NCLEX where there was no computers. We had to go for 2 days for 3 hours twice a day.
She
That's
has
gonna
only
be
2 items.
I'm sorry.
She has only 2 items. After you have to go back to school.
You have to go back to school. You made, okay, so people are putting in there, yes, only 3 attempts.
What do you mean by back to school? It's just like a basic recovery class just to prepare for NCLEX?
It's like a
that would be a
course.
question you would have to ask you could ask the Board of Nursing. The Florida Board of Nursing, you can go on their website and it should tell you what you would have to do to if you know, but think positive. You're gonna study and you're gonna practice and you're not gonna fail. Think positive. You got to be positive.
I'm trying.
After
Because the
somebody
first
put
time
in
when I
there,
took it, I felt so good. I felt like I left the play. I shut off on 85 and I felt good. And then I received bad news. So it's kind of
right.
was tough because you don't know.
So don't take that as so negative. I know it's disappointing, but take it as a learning opportunity because you said you just wanted to take it and see what happens. So go through and look at the report, kind of look at it in a little more detail and see what areas you need to focus on. Analyzing cues, evaluating cues, hypothesizing cues are all of those upper level critical thinking modalities that NCLEX does. Are you working in a facility right now?
No, I'm just trying to focus 100% on passing.
Okay. I was just gonna say, you know, talk to people if you go to work and apply what you're learning. That's the biggest thing.
Yeah,
How
that's
did
the
you?
problem. I don't have any experience in any medical field. So for me, it's everything new.
Right. So did you not have clinicals in your program?
I did, yeah, of course, but
Okay.
it's not enough to get the experience.
Okay. Yeah, somebody said don't give up, give it another try, use the report to study. Yeah. I mean, without seeing your report, I can't analyze it and look at it. You know, just read the report. It should tell you the areas to focus on because the NCLEX is broken down in categories.
Yes.
You may also liaise with NCLEX chat assistants if they can link you with individualized tutoring. There you go. You are in the right track. You need a little bit coaching to keep your confidence and critical thinking accurate. Exactly. Yeah. I mean, think positive. Don't think negative. You know, continue to listen to the sessions because there's a lot of information that all of the tutors on this NASLEX site give you and provide about all the different content. Ferdinand put in here that tomorrow is on I think it was maternal health or something. So, I will be quite honest, maternal health is not my forte. I didn't like being pregnant and I struggled with that. I can talk to you about the medications used all day long, but maternal health is not my thing. So yeah, I don't teach that one. Follow this lady on YouTube. So I would be careful with the people on YouTube.
I was just
because
about to say that, Professor. I was just about
yes,
to tell people like we need to be
yes,
careful of how
because
many resources you're using to study. If
yes,
you want to stick to one, it's
anybody
better.
can make a YouTube video.
That's
And
right.
there's all kinds of, graduates who go out there and they make all kinds of YouTube videos. So they're not always the most evidence-based. They are very opinionated. So just be careful. You have all the tools right here on this site. So
I
on
like this
NCLEX,
simple
you have
nursing. It's kind
tutoring.
of for visual people.
I'm sorry.
It's called Simple Nursing on YouTube. He's kind of
Okay.
breaking like more like Picmonic, you heard of the website?
I have heard of Picmonics. I love
Yeah.
Picmonics.
So it's like more like for visual people who like memorize visual.
So yeah. So but you have a site right here, y'all. Focus, yeah, like Nick said, he was about to say focus on NASLEX. I mean, I do the same thing with my in-person students. Everybody wants to get more and more and more and more resources, but you have resources right here. I mean,
Yeah, that's what I'm
really
doing. I'm focusing on NCLEX website because it's really helped me and it's look
yes,
almost
yes,
dedicate, sorry.
yes.
It's very similar to the way how the real NCLEX looks.
Yeah,
Right.
because it's not safety to be all over the place looking for different reviews, and you at the end you
No.
get all confused because everybody
Exactly.
everybody teach different.
Yes, exactly. I have my colleagues that we graduated together and have taken the NCLEX some months ago. They all recommended NASLEX. Yeah. So, you have resources right here. Use those resources, use what you have and go from there. It's getting a good study plan and dedicating time to doing it every day, and find those areas that you were weak in. You have to look at your report and kind of analyze it and then go from there.
Thank you very much for everything.
You're welcome. I hope you guys have a good night.
Thank you, Professor. You're the great. God bless you.
Professor, is there a way you can help with strategies of how to take exams?
I can't hear you.
Is there no way you can help with strategies, of how to take the questions? Like I'm lacking in that.
So I do strategies all throughout, especially when we're answering questions. I did a partial test taking strategies the other night. I'll do one again next week with one of the lectures. So, just practicing and reading up on the areas. I mean, y'all look at what areas you don't know. I mean, I know my weakness. My weakness is OB. If I was to go take NCLEX tomorrow, I would definitely have to study OB. So identify what areas you're the weakest in the content, and then review that content, but then practice the questions because that will help you with those higher level learning, the analyzing click cues, hypothesizing cues, and evaluating cues. Does that make sense?
Yes, Professor. Thank you.
You're welcome. You all have a good night.
Good night, Professor. Thank you so much.
Good night.
Good
You're
night.
welcome.
Good night.
Thank you so much, Professor.
Yes.
Thank you, Professor. Good night.
Good night.
Thank you, Prof.
You're welcome.
Thank you, Professor.
You're welcome.
Good night.
Prof, thank you.
You're welcome.